We've all had patients say, melatonin doesn't work for me. And to be honest, it often doesn't, at least not in the way that most of our patients are using it. Melatonin is not a sedative, it's a chronobiotic. It's a biological time cue that tells the body when it's nighttime. It regulates the sleep-wake cycle. So when a patient says to you, melatonin didn't work, the issue usually isn't the melatonin itself, it's that it's the wrong timing, dose, or indication. So let's talk about that today. I'm Dr. Nishi Bhopal. I'm a sleep physician and psychiatrist, and this channel is for you, the healthcare practitioner who wants to learn practical, evidence-based insights into sleep medicine. Today, I'm going to walk you through 2 real cases that show why melatonin fails and how to make it actually work for the right patients. Endogenous melatonin secretion starts roughly 2 to 3 hours before habitual sleep onset. This is known as the dim light melatonin onset, or DILMO. It doesn't induce sleep directly, rather it prepares the system for sleep by signaling that night has begun. So let me tell you about the first case. This was a 32-year-old woman who came to me for treatment of insomnia, and she said melatonin didn't work. She'd seen multiple psychiatrists, she'd been prescribed hypnotics, trazodone, Ambien, she tried them all. At this point, she was taking Benadryl every night to knock herself out to sleep. She had previously tried 5 milligrams of melatonin at bedtime with no benefit. So what do you think was going on here? Well, she didn't actually have insomnia. When I took the history, the pattern was consistent with a classic presentation of delayed sleep phase disorder. She couldn't fall asleep until about 2 or 3 a.m., and she struggled to wake up in the morning for work. So for her, her bedtime was physiologically too late. It was misaligned with her daily obligations. And she was using these hypnotics, these sedatives, to knock herself out, when the problem wasn't actually insomnia, it was a delayed body clock. So melatonin is actually highly effective in these situations when used correctly. So here's what we did. Instead of a pharmacologic dose of melatonin, like a 5 milligram dose, we used a physiologic dose, 0.3 milligrams. This was taken 5 hours before her target bedtime. Doing that over the course of several weeks in conjunction with light therapy and shifting her rhythm helped to advance her circadian phase and stabilize her sleep schedule so that her sleep schedule was more aligned with her daily obligations. So for delayed sleep phase syndrome, low-dose early evening melatonin given around dinner time actually advances the circadian phase. I share more about this in the phase response curve video, so check that out for more detail. When you hear melatonin doesn't work for me, it's almost always one of these 3 things. Number 1 is timing. Bedtime dosing is too late if you are working on circadian shifting. Melatonin should be given relative to the dim light melatonin onset, not clock time. The second reason is that melatonin isn't actually for primary insomnia, it's for circadian realignment. Things like delayed sleep phase, advanced sleep phase, jet lag. There is a role sometimes for insomnia in certain cases, which we'll talk about in a moment, and other indications as well. But melatonin is a body clock regulator, not a sleep aid. The third reason is melatonin quality varies widely. Some products contain a fraction of the labeled dose, whereas others contain several times more. A few have even been found to contain serotonin. Check out my last video for more detail about that. And if you're not sure which formulations to trust, I've put together a melatonin brand guide for clinicians. It's a practical list of products that are tested for accuracy and purity. You can download it using the link below or go to IntraBalance.com/melatonin. Here's a clinical pearl. For most sleep-related indications, a dose of 0.3 to 3 milligrams is sufficient. Higher doses may be used for other conditions like REM behavior disorder or certain pediatric disorders, in addition to non-sleep indications like inflammatory disorders. But for shifting the circadian phase, less is usually more. Tell me in the comments, when your patients say, melatonin doesn't work for me, what do you usually find is at play? Share your experiences in the comments below. Now let's contrast the case of the 32-year-old woman with delayed sleep phase with another case. This was a man that I saw who was in his 60s who kept waking up around 4 a.m. That was his terminal awakening, and then he wasn't able to go back to sleep. He would fall asleep easily around 8 or 9 p.m., but he was waking up too early. So is this insomnia? Is this early morning awakenings? Well, in this case, he actually had advanced sleep phase disorder. In a patient like this, we use 2 milligrams extended release melatonin at bedtime. And this helped to improve that patient's sleep continuity and actually shift his bedtime a little bit later. In older adults, endogenous melatonin secretion often declines earlier in the night, leading to early morning awakenings. And in older patients, we may see an advancement or a shift in their body clock to an earlier phase. So the extended release formulation helps to maintain physiological melatonin levels into the early morning. It compensates for that drop off in the early morning hours. There's good evidence behind extended release melatonin in older adults. In fact, 2 milligrams of melatonin extended release, also known as circadin, is approved in Europe and other regions for the treatment of primary insomnia characterized by poor sleep quality in adults over the age of 55. Multiple clinical trials have shown that extended release melatonin improves sleep quality, sleep latency, morning alertness, and even health-related quality of life in this population with a pretty favorable safety profile. And there's no evidence of dependence, tolerance, rebound insomnia, or withdrawal symptoms. The American Academy of Sleep Medicine notes that the effect sizes are generally small to moderate, but clinically meaningful for selected patients, especially those whose endogenous melatonin wanes early. So again, this is a different physiology and a different solution. This is why understanding how to use melatonin strategically is so important, especially when you hear from patients that melatonin doesn't work. In this case, the extended release melatonin wasn't working as a sedative, but it was restoring a physiological signal that declines with age. So your clinical pearls are for delayed sleep phase, early evening, low dose immediate release melatonin works best. For phase advance or for insomnia in adults over the age of 55, bedtime dosing of extended release melatonin around 2 milligrams works best in those cases. If you're a healthcare professional who wants a deeper dive into evidence-based sleep supplements, join my free sleep supplement masterclass for clinicians. Choose from November 12th or 13th, 2025. This class is designed specifically for physicians, therapists, coaches, nurse practitioners, PAs, and other healthcare practitioners. So if that is you, register at IntraBalance.com/masterclass. Remember, melatonin rarely works in isolation. We don't use supplements alone. We need to implement other sleep promoting behaviors like regulation of light exposure, regular routines, consistent behavioral cues, working on hyperarousal, working on the sleep drive, making sure there's no sleep apnea or other underlying conditions. We need to look at things holistically in order to fully stabilize sleep. It's unlikely that melatonin alone is going to do the trick. Melatonin is also known as the hormone of darkness. It's like a little vampire. So it needs an environment of darkness in order to fully work. So if you're taking it in a bright room or you're looking at bright screens, it's like you're scaring that little vampire away. We need to create an ambient environment that's dark to invite that melatonin to have an effect. And if you missed my video on melatonin supplement quality, check that out next.